So today our webinar is about artificial intelligence in health and pediatric health data. And we have 4 speakers. And before we start the webinar, I will make a brief presentation about EPTRI and our 4 speakers. So EPTRI is a distributed research infrastructure that offers high-quality services in basic, preclinical, and translational pediatric research. EPTRI is composed of 5 thematic research platforms, and it is structured to enhancing technology-driven pediatric research in drug discovery and early pediatric medicine's development phases by providing expertise, facilities, and methodologies focused on basic research for pediatric medicine discovery. Its mission is based on recognizing the importance of growth and ontogeny characteristics in pediatric drug device response and the integration of preclinical and clinical research. This 6th webinar is organized within the 1-year educational program set by EPTRI Paediatric Medical Devices Platform. During this webinar, we will delve into the benefits of artificial intelligence for collecting and managing pediatric health data, but also the challenges and best practices for its use. Our first speaker is Andrew Taylor. Andrew is the Director of Innovation at GOSH, responsible for the Digital Research, Innovation, and Virtual Environments Drive Unit, the Cell and Gene Therapy Manufacturing Facility. Oh, hello.
Hello.
And New Pediatric Innovation Hub. He is an expert in cardiovascular imaging and has established the Center for Cardiovascular Imaging at GOSH. Andrew has also expertise in the use of data in AI in healthcare, including data and AI governance, and the use of virtual reality computer modeling and 3D rapid prototyping in healthcare. Andrew will talk about artificial intelligence in hospitals, how to deliver it, convince the institution to use it, and how to have it in place. He will also talk about the data and bias and mention use cases. And now I will give the floor to Ari Melamediekel, who will be the chair of our webinar today. So you can start from our second speaker, Luis. Thank you, Ari.
Thank you, and I want to apologize for the inconvenience. It was like a problem of time syncing. I thought that it's going to happen in an hour, so I apologize in front of everyone. Our second speaker of the webinar is Luis Fernandez Luca. He's the Chief Scientific Officer at Adhera Health, Inc. Luis is also a senior member of IEEE Engineering in Medicine and Biology Society and Vice President of the International Medical Informatics Association. His research focuses on the adaptation of mobile and web technologies for patient support and public health. He has substantially contributed to the creation and validation of artificial intelligence applications based on mobile and wearable technologies, including technologies such as deep learning and health recommender systems. Luis will discuss about data challenges, mainly the integration of more than clinical data like psychology, physio-social parameters to reduce data bias and to identify what is unique in families from minorities. The third speaker is Katerina German. Katerina is the Director of Digital and Innovation Services at the Children and Adolescent Department in HUS, Helsinki University Hospital. Katerina leads a group of experts from different backgrounds working together to improve research and innovation within children and adolescents, including for example, the clinical trial unit and data lake team. She's the consortium coordinator for the EU-funded FEMS, a project aiming to create the decentralized health data ecosystem for European children hospitals, enhancing access to an analysis of health data while ensuring GDPR compliance and data privacy. Katrina will present the FEMS projects, namely the data ecosystems, work packages, and partners. Our last speaker is Timothy Chu. Timothy started his career at one of the original Silicon Valley startups, Tandem Computers. His commercial career includes serving as the first president of Oracle Cloud Computing Business, and today as a board member at several public and private companies. He's invested in and been contributed to several startups like WebEx. Today, he serves as the chairman of the Alchemist Accelerator, focused on B2B startups. He also launched Stanford's first course on cloud computing. Recently, Timothy has devoted his time to his last great project, the Paediatric Moonshot, a project aiming to reduce healthcare inequity, lower healthcare costs, and improve outcomes for children locally, rurally, and globally by creating privacy-preserving real-time AI applications based on access to data in all 1 million healthcare machines, in all 500 children's hospitals in the world. Timothy will speak about the Pediatric Moonshot and their different programs. We will conclude with a Q&A section where the speakers will answer your questions. If by some reason you will not be able to raise your questions verbally, so you are invited to put them on notes and send them using the chat. And with that, I would like to invite our first speaker to start and kick off the session. Please, Andrew, the stage is yours.
Thank you so much, and thank you very much for the kind introduction, and thank you very much for the kind invite. Famous Zoom words, I will now try and share my screen, which is there. There, so I'll wait for one nod that somebody can see what I've put up. I hope that's the case. Yes? Excellent. So welcome everybody. So what I'm going to try and do today is really just give you an example of a use case that we've worked through that's really helped us define many of the things that in hospitals we often worry about as we might begin to implement clinical AI solutions. Just as way of acknowledgement, the use case that I'm going to use is a collaboration that we have with a small UK startup company called Tortoise. So what about real-world use of clinical data for machine learning and AI? So I think the first thing is, I will put this in very simplistic terms, I kind of see AI as being able to do two things. Firstly, you can classify something, make a diagnosis. So actually we see that with mammography. We've seen that AI is very, very good at the early detection on mammography of breast tumor. And one might argue with some of the data that's out there, actually probably better than a radiologist. The second thing that we can do, and I guess this is when we move into clinical decision support or patient decision support, is begin to use the data that we've got, the images that we've got to predict what might happen next. If I come into hospital, I have COVID, what might be my length of stay given the condition that I've got? Those sorts of prediction models. And for many of us, this clinical decision support and patient decision support we're not completely sure if that's the right thing that we should do. I would actually say for many of the things that we could test and try in hospitals, some of that operational decision support making might be the first place we start. However, or probably why I'm going to talk is if you look at machine learning and AI, it is a tiny, tiny little bit of what is necessary to deliver these really exciting opportunities to our patients. There's a huge amount of work that needs to go on, and for our hospitals, a real change that needs to happen. We know, if you ask anybody who wants clean data, Everyone puts their hand up. We also know if you ask the question, who actually wants to create the clean data? Nobody wants to do that. Tumbleweed. But all of these things are super important if we want to create the environments in which we're going to deliver safely for patients and for clinicians the opportunities that AI and machine learning or clever computing may bring us. So what's the kind of, I speak very much from an NHS background here. So we know that there are increasing requirements. People want to use informatics and data science, but we've got discrete areas performing multiple tasks. So in our own setup, I have an information services team. We have an electronic patient record team. We have an ICT team. I have a data team that are trying to take data and some of the work that we're working with Katrina on. And actually, a lot of these activities at the moment aren't coordinated. And what I would often say is, actually, if we think of AI tools, they're not like normal things that we're trying to implement. It's not like a piece of software that you might install one day and 5 years later you might need to update. This is something that you install on day one, or however you use it on day one, but could be very different by day two. So we're going to have to work out ways where we interact and monitor the solutions that we're going to use. At the moment, in our health service, there's no department that does this. There's no person whose job it is to try and implement AI or machine learning solutions into a hospital. And that's despite much of the UK system really driving strategically how we're going to do this. So there is this massive underuse of these opportunities. And so if I look at that current situation, slightly haphazard, I think what we've got to do and move towards is a much more coordinated response that involves many more people. And actually, in medicine, particularly in pediatrics, we're very used to doing that. It's fundamentally a multidisciplinary team that's going to drive these things forward in the future. So if we go back to those things, there are lots of issues, practical, and well, you can see them as issues, but you can see them as opportunities for hospitals that are going to deploy. In the NHS, there are financial models. Just simply, most of the computing in the NHS is on premises, so stacks of hard drives that sit within areas within an ICT department will move to the cloud. Completely different financial model. What is good enough? I install an algorithm on day one and it's 94% accurate. By day two, it's 85% accurate. Who makes the decision that's good or not good enough? And how do we monitor that? And so, and then the final thing is, how much do we actually tell a patient in a funny sort of way? So if I give a patient advice, I don't say, I read this radiology textbook, but it may be when I use an AI algorithm, I might say, this is what I used. And it may be that some patients will say, well, why didn't you use such an algorithm? So lots of things that we need to think through. So I'm going to go through a use case. So the first thing this is really a use case about how we might improve the experience for both the patients and the clinicians in an outpatient clinic. So we know when we go to any clinician, if we go to the doctor, if we go to our general practitioner, whoever we go to, we sit talking to somebody who's usually typing as a computer. And that really breaks that patient-clinician interaction, often facing the computer, looking towards you, typing on the computer. The other bit of it is we know from electronic patient records for researchers like myself, they're fabulous because suddenly we now have lots and lots of structured data. But for the clinical teams, putting that data into an electronic patient record is really very, very cumbersome. And actually, we can see quite a lot of, and we've just written a paper, almost this cognitive burnout related just to this laborious task of entering data for patients. So actually, if you're a nurse in a room, you might write on a piece of paper the observations that you've taken, then go back to a desk, sit at a computer and type those into an electronic patient record. So how could we make this experience better? So we've, as I say, worked with a small UK AI company called Tortoise. And we basically, that is an ambient technology that will listen to the conversation and create a dictation. That dictation is then run through a large language model, which we've templated, that will basically create instantaneously at the end of the outpatient or the GP consultation, a discharge letter. So the idea being that you don't need to type on your computer, and from a patient perspective, does that give you a better experience? So for right or for wrong, and actually I had somebody feedback this wasn't necessary, but I'll explain why I think why we did it, is we almost thought of this as if you were running a drug trial. So your phase one is in a sandbox, build your minimum viable product to make sure that this works. The second phase was then a controlled study in which we took actors and clinicians and mimicked outpatient appointments to see how that would work. And we've just completed our third phase of the study, which is now basically using 200 families, so pediatric patients in the hospital environment with the clinicians that are looking after them. And then we're going to start a fourth phase, which is actually how do you scale this? But I'll mention that in a second. So in that phase 2 study, so this is now actors plus the clinicians, we saw that actually you improved. We found a way of measuring how good a letter or a discharge summary was. And we found that actually you improved the quality. So actually overall, the quality of those documents that are going out to the patients, to our other colleagues, was increased. We saved 25%. Interesting, we didn't reduce the amount of time you spoke to a patient at all, but we saved all that admin, all of that typing. So suddenly, could you get, I think that's probably overstating, could you get a quarter more patients through an outpatient clinic? When we asked the patients, they felt it was kinder. The clinician was talking to the patient now and not to their computer. And actually, it probably ends up being safer because from those letters, we're then able to automatically populate areas that clinicians might not have done in such a good way, particularly around coding, so on and so forth. So we've just, as I say, we've just completed our phase 3 study. I don't have the results yet. We've just done the 200th patient, but we're kind of looking at that in a pediatric setting. And in a real world setting, I'm sure the results will be slightly different. For us, though, as a small pediatric hospital, we're also interested in how do you scale these sorts of models? So how do we make this for adults? How do I make this work for adults in community? Does it work for mental health? Does it work for ambulances? Does it work for general practice? So we're now using all of the areas that we've learned to now basically drive this as a study, so to develop and iterate what we've found in the pediatric population into a broader population. Doing this, we've learned a lot. So fundamentally, we have learned an awful lot. We took legal advice at the start of this collaboration. We have created contractual advice about how you interact and drive forward these processes. We've built infrastructure, so some of the data infrastructure that Katrina will talk about to make sure that our data is in a usable space, but also that it's clearly anonymized and de-identified. We've learned an awful lot about governance and how you drive these sorts of projects through, funding, as I've alluded to, the delivery, and also then the monitoring. So I'm going to touch on a couple of these. So from the legal advice and the contractual advice, that's been super useful and has given us lots of cover as we've actually pursued some of these phase 4. From a governance perspective, though, we as an organization really sat and thought, what are the sorts of AI algorithms at this point in time do we want to look at? So the first thing is, so we took the Hippocratic Oath and also what's called Asimov's 3 laws of robotics to create 3 laws for us at the moment. So if we wanted to change these laws, we would need to go to the trust board of the hospital. And at the moment, there's clearly, we mustn't do harm. This must be about the well-being of individuals and we must prevent harm. It's got to be equitable, unbiased. So that equity and that confidentiality is super important for us. And at this point in time, if any decisions are being made by an algorithm, they have to be under human clinical supervision. Now, that may change over time. We'll undoubtedly, as we become more comfortable with these algorithms and the risks, we may shift that. And also what we've then done is we've said these algorithms must be patient-centered. They must be thoroughly evaluated. So in that example I gave of those phases, somebody says to me, well, actually, you're not using something that's making a patient or a clinician decision. Why do you need to run all these phases, through all these phases? And my response to that was, we've got to make organizations who are quite fearful of what AI may bring and the risks that are potentially there through a whole journey that makes them feel comfortable so that at some point in time, these processes can become more automated. The security around cybersecurity.
Andrew, 3 minutes.
No worries. Data protection, data security, cost effectiveness, so on and so forth. The other thing from a cost, they're slightly different for AI. So you buy a platform, which often isn't particularly expensive, but you are going to need implementation and service costs. And then you have these calls that you make. So almost like the fuel in a car, these APIs that you're going to need to work out how you fund. Once you've established these, so we're in a proof of concept time, we've got to transform our hospital and we've got to be able to monitor. So this virtuous cycle of innovation, transformation, and quality improvement. And then finally, the way that we think we'll land this, and you'll see that I saw an AI hub, is actually by this creation of a clinical intelligence unit, which will bring together data analysts, data scientists, data engineers, with governance teams, with clinicians, with the people that are using these technologies, such that we can drive advanced analytics, but make sure that the AI algorithms that are driving them are also safe, and therefore we monitor and alleviate any risks there may be. So I think in conclusion, AI is only a small, to a degree, the use case that I've taken actually enabled us to address all of those issues that I've been through as we work through them one by one. But the AI bit, so you could substitute any tool into this process, is actually a very, very small component of what we want to do. As I've said, running through a use case really has helped us focus so that the next use case will take less time. As we'll see from many of the other speakers, there are huge opportunities that we know that will come forward, but we must acknowledge, particularly in what are fundamentally quite conservative organizations, rightly so from a patient safety perspective, that we've got to do this work very carefully to make sure those risks and anxieties are covered off as we advance these sorts of technologies. So thank you very much. Hopefully spot on in my time, and I'll clearly answer questions later.
Thank you, Andrew. Indeed, spot on time. Questions, as Andrew said, will be taken later. I would like to invite our next speaker, Luis. Please, the stage is yours.
Hello, thank you, everybody. You hear me well, right?
Yeah.
Let me share the screen. And you see the presentation, right?
Screen is perfect.
Okay, thank you, everybody, for being here, and especially EPTRI for the kind invitation, and Ari for your managing of the panel. So today I'm going to speak about how we can use responsible artificial intelligence to support families involved in pediatric care. First of all, I would like to emphasize, as Andrew mentioned, that this is not something new or that it will happen, that actually has been already going on for some years. Actually, there is a very nice review from Paul Dimitri that actually is attending about how AI can be used, for example, in pediatric endocrinology. We know that there are many examples in diagnosis, like analyzing pictures or faces of children. There have been also examples in the management of chronic conditions, like some of them quite long time ago, even 20 years ago. And there are things related to supporting research to better understand, for example, things behind childhood obesity. All of those applications, they are not the same in pediatrics that in adult care. And I would like to emphasize a little bit what is unique in children that we should be aware of before we jump into applying AI into this domain. We know, especially when we are dealing with families, that we need to pay a lot of attention to the social determinants of health that involve schooling, family, education, economic factors like the income of the parents. And in addition, to make things more complex, we need to consider that children are not the same. The children are evolving very quickly. You have differences across sex. The different age are quite different for many chronic conditions. And sadly, many of those social determinants of health are not yet into the electronic health records, and sometimes they are not structured, so they are harder to analyze. Also, when we are dealing with families and with children, including teenagers, many potential ethical and legal aspects may actually appear. Things like when a child may be able to join a community of other children may be also regulated. In top of this, we need to take into account the context of care. Clinicians, they have more and more data across many different chronic conditions. Not all the data is of the same quality, but we know that clinicians are not having necessarily more time nowadays than 20 years ago when my grandfather was actually practicing medicine. And on top of that, the tools are becoming more complex, but we don't necessarily spend more time training those clinicians on how to use such tools. At the end of the day, this is a brilliant scenario with many potential challenges and opportunities, but we need to emphasize the risk of applying AI in pediatrics if we don't do it in a responsible manner. We know that sometimes the algorithms will have a bias, like that paper about the prediction of childhood that I put in there in the left corner already described that the algorithm wasn't working as well in some ethnicities. So you may actually have a potential bias that actually may be increasing health disparity. We also know that there is not a very good standard on how to report machine learning studies in pediatrics. And overall, in a very recent review, they found out that the quality of reporting was actually very poor. In another study that was published in Nature Digital Medicine, they highlighted things like in many studies, they were not reporting the age of the children. You may have an average. If you have an average and you have one child that is 1 year old and the rest is 15, that average is a little bit meaningless from a pediatric point of view. And then we know that very often those algorithms are not done with the stakeholders involved. And many times the application has been in a lab, in a pilot. So it's not actually something that you can extrapolate to the busy clinical practice. On top of that, especially in Gen AI, we know that those algorithms are learning from the internet, open data sets, and that means that the algorithms are also learning potential harmful things. Like in that report that you see on the right, they report how you can use ChatGPT for creating content promoting anorexia as a lifestyle. And nobody's checking what will be the advice in ChatGPT about insulin doses, etc. There are some safe words, but they may be not good enough. When we are applying a new technology, we know that there is a huge potential for increasing inequality. And this paper from several years ago, dealing about how inequality may be actually exacerbated by incorporating digital health, highlight the different levels that you need to take into account. You have inequities already in the baseline, like different population, they may have different genetics, etc. You may have different inequalities in access. We know that health minorities typically have more issues to access the patient portals, and then also in the adherence, how people engage with the different solutions, and then also in the effectiveness. Like we know that some technology may work less in some populations. So we have a huge potential of actually making things worse if we are not careful. How you can overcome this, actually taking into account those disparities, your population, very early on. It's extremely important to always consider how the social determinants of health may play a role into the solution. Also, how to work in the underserved populations. And it's very important to bring all the stakeholders so that you can identify the need for new skills and also to gain the trust into the system. Inclusive design is a must, because otherwise you may have issues related to the usability and the literacy. And always you need to check whether the solution is working as advertised when you put into the different contexts. This may sound very complicated, but in reality, it is complicated, but you are not alone. In the last few years, there have been actually many different guidelines that have been developed and adjusted. Like, for example, EPTRI have one that focuses on how to do responsible AI. UNICEF also developed a guideline on how to take into account ethics when you are dealing with children, because you are also trying to foster their autonomy. The FDA also have a framework explaining how to do AI in the medical domain, but taking into account the entire deployment, auditing, so the entire process. And in pediatrics, there are also some guidelines on actually how we should do this reporting. And this is very important because right now, most of the studies are not following that guideline. And the challenge will be later on when we are trying to compare the different solutions if the reporting is different, there is no way that we are going to be able to compare to see what is working and how. And at the end, all those frameworks, they help you, but they need to be adapted to your context. And that context may change from country to country, from different conditions. And the only way to learn about that is actually involving the different stakeholders. Now I'm going to explain very briefly the things we do at Adira Health with the different stakeholders. So we have taken into account all those guidelines to figure out how we can adjust our programs or solutions to support families of children living with chronic conditions. For that, we use evidence-based guidelines and programs. So we include educational content that is backed by research. We involve people with different backgrounds, data scientists, psychologists, nurses, medical doctors. And one of the things we put a lot of emphasis is to understand the biopsychosocial domain of the people living with chronic condition. Biopsychosocial means taking into account the biological elements, like the physiological element, the psychology, and the social, because that helps us to better understand the entire family so that we can adjust to them. That's particularly important in chronic conditions like obesity, diabetes, and growth disorder that we are working on, where we know that there are many factors that are affecting the management of those chronic conditions. At the end, to do all of this, you need to do a participatory approach where you involve the different stakeholders very early on. For example, in the US, with the funding from the NIH, the National Institute of Minority Health and Health Disparity, we are conducting a lot of workshop with people with different chronic conditions, with different families, so that we can learn their context and we can better adapt to their particular needs. How we do that? We also use some frameworks that help us to try to learn all the different levels of those families so that we can foster the personalization. That includes, as you can see in this framework from the right, related to how to build digital health equity, you need to take into account individual levels. That can be the psychological status, self-efficacy, how you use the art to the different technologies, but you need to also look into the family, the different interpersonal factors, like the relationship between the families and the clinicians, between the parents and the children. And at the end, people living with a chronic condition, they are not living in the cloud. They are living in a very concrete community. So for us, it's very important to adjust to the different communities. In the case of the US, this includes like the Latinx community that we have a strong focus on. It can be also the diabetes community or the local community, for example, in cities like Los Angeles. And all of this need to be also done according to the societal factors, and that include policy issues, safety, and the emerging issues of potential algorithmic bias that we always take into account when we are developing solutions. In short, we can make this work, but we need to make it responsible, doing our best to support the families and the clinicians that are working with them.
Luis?
And that was all. Thank you.
Yeah, wow. Amazing. Thank you for the enlightening presentation, and thank you for being in right spot on time. I would like to invite our next speaker, Katarina German. Please, the stage is yours.
Thank you very much, Ari, and thank you very much for inviting me and for the introduction. So my name is Katarina Germa. Unfortunately, everybody who's online, my camera stopped working today on my laptop and I could not fix it before the call. So that is why I unfortunately don't have my camera on during the presentation. But let me just share my screen. Please let me know if you see my screen.
Yes, we do.
Perfect. Thank you very much. So hello, everybody. My name is Katarina German. As said, I'm the Director of Innovation and Digital Services here at the Children's and Adolescents Department at the Helsinki University Hospital in Finland. And today I will give you a presentation or talk a little bit about our EU-funded project called, and EU and UKRI funded project called FEMS, which I am and which HUS, the hospital is coordinating. And as a kind of a standpoint, the slogan of our EU project could be building European children's health data space. So I will actually talk a little bit more about how to develop the infrastructure so that we can enhance the use of AI and federated learning and big data use within pediatrics, especially inside Europe. So maybe a short why we have this project, and why we think that having a consortium working on the infrastructure of using federated learning and AI use and enhancing children's development and innovation and research is important. As already pointed out today before, is that we all know that we have often small numbers of complex pediatric and rare diseases per country, and thus the volumes and numbers are often very small. And thus to be able to work with data, we need collaboration between different children's hospitals and different countries to get big enough volumes to work together. We also know that there is limited real-world data for expensive therapies that are, of course, very important with children, especially with rare diseases. And we also know that children and adolescents are often underrepresented when it comes to research, for example, in pharma, but also in medtech. And that's why there is a need for engagement with the medtech industry, with pharma and innovation ecosystems, to really support and enhance the research and innovation with children. And very often, not of course always, but very often there are only a few tertiary hospitals in countries treating children, and that is why it's really important to enhance the use of shared benchmarking and shared data to ensure that we really all work together to increase the use of pediatric data. So what is FEMS? Very shortly, as said, it's a EU and UKRI funded project. The project lasts for 3 years. It is totally funded by the UK, by these research institutions. We have 14 partners, including hospitals, universities, technology, and biotech companies from all around Europe. And if you look here at the list, you can see all our hospitals and universities and technical and business partners. We have 6 children's hospitals joining this EU project from different areas from Europe. We have HUS, the Helsinki University Hospital. Then we have Erasmus Medical Center from Rotterdam. Both of these are big general hospitals with pediatrics as well. And then we have pediatrics focused hospitals as the Great Ormond Street Hospital for Children, where Andrew comes from. We have Sant Joan de Déu from Barcelona, Children's University Hospital from Latvia, and the Meyer from Florence. And also University College London is a partner in the project. We have also technical and business expertise within this project. We have partners from different countries. Veil AI is a specialist in anonymization synthesization from Finland. Genesis Biomed works especially on exploitation related to the project and a business model. They come from Barcelona. The Hive is a specialized company related to harmonizing data, which is very important when we work with federated data. And EPTRI is a multinational company working on infrastructure in this project. And Iridia is a Scottish company specialized in federated analytics and learning. And what do we then actually do? So the project is, we are creating a decentralized and open health data ecosystem that has both technical components, governance frameworks, and use cases to really see that we have an ecosystem with data, with governance that technologically works, that we can actually share data in a federated way. And that means that the data does not leave the data controller, which is the hospitals in our case in the project, but actually we just share outcomes or aggregated values of different kinds of algorithms within the project, within each other. And if I then go to the next slide, this is a very overall picture of the project, and I will walk you through very shortly, as in what we actually do in the project. And as said, the kind of the core of the project is to develop a federation analytics network. And this means that we have actually 4 hospitals in this project that all have data lakes and all have very large sets of data from different from longitudinally from different years. And what we are doing in the project is that we're creating a federated ecosystem network where all of these 4 hospitals share aggregated data or outcomes together, connect to each other, but do not compile and share the data on a raw data level. And what this means is that we don't create a repository of data for this project, which is often done, right? A registry. We don't have a project-specific registry, but we actually have a network of hospitals with their own registries, and they just then share the actual outcomes, which from a privacy perspective that was already discussed today is very different from developing and creating one big registry with all of the data together. In this federation analytics network, we will then also develop synthesization and anonymization techniques, which means that we will use real-world data as a starting point to develop algorithmically anonymized and synthesized data, which means that it is GDPR-free and it is non-personalized, and it should be so anonymized that a patient cannot be, that it is not real patient data anymore. And for everybody online, if you haven't heard the word synthesization before, synthesization means that you develop a new data set from a real world data set, which mimics real world data, but is actually totally synthetic. So it is not real world patient data. And in this project, we want to test if this synthetic data works as well as real world data in research or in benchmarking as well, to test that to see if synthetic data actually could be potentially used in the future to support, for example, innovation within pediatrics and of course in healthcare in general. When working on ecosystems and when really developing ecosystems, it's really important to take governance into mind as well. And that is why we have a large chunk of the work in this project will be worked on the governance - legal ethical issues, as in what does it really mean that we create an ecosystem like this, and what is the roadmap? What do we really have to take into account? And we will be developing a playbook to really see, as in what kind of things need to be taken into account to create this ecosystem, and on the other hand, if others and when hopefully other hospitals want to join also after the project, what is needed from a new hospital to actually join such an ecosystem for aggregated data sharing. Nothing of this would be, of course, possible without real-world data. And that's why we have three use cases in the project, which focus on three quite different cases within pediatrics. We have the clinical use case, which is use case 1, the cardiology patients operation management case. We have the second one is a pediatric intensive care unit sepsis case, and the third case is hematology and hemophilia. And I will. If you look at this slide shows all the different use cases from a little bit deeper perspective. So in the first one, the use case 1, we really want to develop and create benchmarking between the 4 hospitals in the project that have a data lake, and hopefully, of course, enhance it and enlarge the amount of hospitals going forward after the project as well. And the idea is to really use federated learning to enhance benchmarking in nearly real time and really create best practice sharing processes to support the enhancement of children care in Europe. And it is led by Gosh and Andrew. And then the second use case, as said, is our sepsis use case, where we will develop and train and test algorithms to predict sepsis in the ICU unit. And it is led by Sant Joan de Déu from Barcelona. And our third use case focuses on developing and testing machine learn-based prediction algorithm for hemophilia A and B to improve the treatment of the patients. And this is led by Erasmus University Medical Center Rotterdam in the Netherlands. And the whole idea of these 3 use cases is that they test that this federated system works. The idea is to test and validate that the system, the ecosystem works, but they also work as the real world data that then will be used when we synthesize data as well, to really use these to see it. Pardon, there was a comment saying something about refreshing the slides. So
I think it's okay now. There was a part that was a bit fuzzy, but it's good.
Okay, thank you. My apologies, but you can see it now. Is it so?
Yes.
Yeah. Okay, could be the hospital's internet network. My apologies for that. And then if we go forward, the last thing, of course, but very important as well, is that when we think of an EU project, we have to think about dissemination and exploitation as well. So we have Genesis leading the exploitation plan and the business case, and ECHO, the European Children's Hospitals Organization, working on this work package and leading it and supporting the dissemination and communication of the work during this project. And here, very shortly, you can see a organizational chart of the project. We have 7 work packages, of which the middle ones are so-called content work packages. So work package 2 works on platform architecture implementation and the development of the platform architecture for the ecosystem, and it is led by EPTRI. Then work package 3 works on data processing functions and also takes into account the synthesization and anonymization of the real world data in the project and the validation of the synthetic data sets. And it is led by Erasmus from the Netherlands. Work package 4 is the clinical use cases and the validation of the ecosystem, and it is led by Sant Joan de Déu from Barcelona. And then work package 6 is our communication, dissemination, and exploitation work package led by Sant Joan de Déu and the European Children's Hospital Organization. And work package 5, which is around all the content ones, because it really goes throughout the project, is our governance and playbook, including privacy and cyber security work package led by the Helsinki University Hospital. So this is really the overall organization of our EU project. And as said, we are working on a children's ecosystem, or an ecosystem for, especially for children's hospitals, for sharing data in a federated way, so that data privacy is ensured and the data never leaves the data controller, that is the hospitals, but so that we can actually still share outcomes in this area or context of children, and often small volumes, especially related to rare diseases, as said. So thank you very much from my side, and thank you for having me here today.
Thank you, Katarina, for the enlightening talk. Our last speaker today is Timothy Chu. Timothy, please.
So Timothy has sent a recording of his presentation due to the time differences, so I will share his recording. Can you see my screen?
Yes, we do. We can't hear, though.
You cannot hear it?
No.
Okay.
I think when you click share, you need to also include the audio from your computer.
Okay, I will try it.
When you click share,
Yes.
when you choose the screen, in options, you have one checkbox that says share sound. So that's the
Okay.
one that.
Thank you. I will try to do it now. Okay, I can see it now. Thank you, Luis.
You're welcome.
Good afternoon, everyone. I decided to do a recording here because local time, I'm in Hawaii today on a family vacation. It's going to be like 3 in the morning. So I'll join you for the Q&A, but I thought I'd do the presentation in a recorded mode. So thank you very much. I'm going to go to share my screen. There we go. So today, in the next 15 minutes, I want to talk to you about distributed AI infrastructure. I fundamentally believe that the centralized model we've implemented up until now for AI and in the consumer world will not work in medicine. I want to show you a new way that will enable us to bring research from the bench to the bedside. Allow me to introduce myself very briefly. I have no medical background. I was the first president of Oracle's cloud computing business. I retired from there, went to Stanford University, started the first class on cloud computing there. And 7 or 8 years ago, I met a very interesting student who had an MD, an MPH, an MBA, and he's chief of pediatric cardiology at the Children's Hospital of Orange County. So some of you may know Dr. Anthony Chang, but Anthony has inspired what we call the pediatric moonshot. So I learned things like, oh, people are still using CD-ROMs to pass data around. And on the other side of it, if we're ever going to build AI in medicine, we're going to need large amounts of data. So we said about 3.5 years ago, we launched a company called Bevel Cloud with a mission to reduce healthcare inequity, lower cost, improve outcomes for kids rurally, nationally, and globally. How are we going to do this? By creating privacy-preserving, real-time AI applications based on access to data from all 1 million healthcare machines in all 500 children's hospitals in the world. So for those of you who are not familiar with it, the fundamental shift in technology, which you now see as ChatGPT, has really been brought about because of an underlying technology called neural nets. And what you're seeing on the right-hand side is a chart from Jeff Dean, who heads up Google Brain, which in essence, this technology is one where if I can bring it increasing amounts of data and increasing amounts of compute, I can get increasing levels of accuracy. So in medicine and healthcare, in order to build scalable, accurate AI applications, we're going to need large amounts of diverse training data. Here's the good news. We have a lot of it. It's in the buildings. It's in the real-time clinical machines, the ultrasounds, the x-rays, the EKGs, the bedside monitors. It's in research labs. It's in RNA sequencers. It's in mass spectrometers. It's even in offline applications, PACSs, and EMRs. Plenty of data in the building. As I started out, my contention is centralized architectures, meaning I bring all the data to some cloud in the sky, will not work for AI in medicine. For I'll say 3 fundamental reasons. One, the amount of data is much higher than a bunch of text coming from the New York Times. As many of you know, an ultrasound study can be a terabyte. Number 2, the privacy requirements are much stricter. Again, you guys are in Europe. You don't have to hear me say this, but increasingly, even governments like Norway are saying Norwegian data is never leaving Norway. And finally, if we're ever going to build real-time systems, we can't do it in a centralized way. So centralized architectures where I bring all the data into one location and then use it to train AI applications works wonderfully for consumer apps. It's never going to work for AI in medicine. Instead, we believe we need a distributed AI infrastructure. A distributed AI infrastructure which fundamentally moves the compute to the location of the data. So these are Bevel Cloud's edge cloud servers, which are in the building at Bambino Gesù in Rome or in Children's Hospital of Orange County. They are twinned to the real-time clinical machines, the real-time research machines, the PACSs, the EMRs, which are all the sources of the multimodal data. And then the data is presented in a standardized way through something we call Edge Data Services to authorized applications. We knew security and privacy were job one when we went down this path. We've engineered over 30 security features, but just let me point to one in the area of privacy management. One of the fundamental issues in privacy is, or the fundamental tenets, is purpose limitation. So we've implemented that by saying, okay, you own the ultrasound on the 3rd floor. You get to decide whether you share with the red application or the green application. So very fine-grained data access control. Once you share with that application, and it could be an orthopedic application, a radiology application, an oncology application, The application could do, I'll say, one of three fundamental things. It could share the information in an authorized way with other applications. It could infer on that data, run inferencing on that data. I built a great diagnostic in fetal echo. I could infer on that in real time. And finally, it could learn on that data. This is the pioneering work many of us are doing in federated learnings, where I'm going to learn on the data without it ever leaving the building. This distributed infrastructure, just to make a point of it, is running in the building. So this is just a picture of a number of different sites that you could imagine such a distributed AI infrastructure could be running in. In North America, I just did a talk in Africa, where we're going to need to pioneer AI medicine when 2 out of every 5 children in the world are going to be born in Africa in the year 2040. And we're not going to build enough medical doctors and medical schools to do it the way we've done it in the 20th century. And finally, since obviously I'm talking to a European audience, we could build a distributed AI infrastructure in Europe. So we've already, this is not pie in the sky stuff, we've already deployed edge cloud infrastructure, distributed AI infrastructure into Children's of Orange County and into Bambino Gesù in Rome. We've actually already done real-time. Remember I said you could share real-time image sharing. That's actually Dr. Anthony Chang. Dr. Wyman Lai has his back to you. He's the head of cardiology. He's imaging Dr. Chang's oldest daughter, and 6,000 miles away, that's Dr. Alberto Tosi at Bambino Gesù observing that ultrasound image. So I started out by saying we think this infrastructure is important because it will give us a path to bring applications from the research bench to the bedside. So we're already working on, we're going to do a soft launch next month on an AI application commons to identify the many research applications out there where a small team, perhaps at UCL, perhaps in Korea, has developed an application, a neural net application, which, trained on maybe 1,000 images, maybe 2,000 images. So that's great, but it's never going to see the light of day. All it does is ends up in a research report, or best case in a GitHub account. So how would translational AI work? So the way we think about it is, let's take that application perhaps for diagnosing focal cortical dysplasia. Let's take that application, port it to the distributed AI infrastructure, to the Bevel Cloud infrastructure. That's step one. Step two is, let's test inferencing in all the sites, and the sites make a choice about whether to do that and see how well it works. And then finally, as I've already discussed, let's use federated learning techniques to learn on that data in location without it ever leaving the building at Alder Hey, and improve its accuracy using larger and larger quantities of data. We have not just focused on technology. As many of you know, governance in this area is quite a bit different than many other areas. So we're actually developing a governance framework we'll be sharing over the next couple months, which delineate both the responsibilities of the machine owner or the data source owner, the platform itself, Bevel Cloud, as well as commercial, or what we call ISVs, or research applications, the responsibilities in the BAA, the DUA, the DPIA, the IRB, to be able to smooth our ability to bring applications from the bench to the bedside. Let me just conclude by saying, if you learn nothing about what I've said today, I'm just going to keep pushing. Centralized architectures are never going to work in medicine. The data sizes are much too large, the privacy requirements much too strict, and the real-time requirements much greater than we've seen in consumer computing. Instead, I believe we need to build a global distributed AI infrastructure. And for those of you who believe that, I invite you, we've just drafted this one-pager. which basically describes a distributed AI lab for pediatric medicine, which will include 32 zones or 32 sites, all imaging machines twinned, over 2,000 servers, and we want to take 8 applications from the bench to the bedside to basically prove out this whole structure, which we believe will fundamentally change how children's medicine and adult medicine work as well. So if you're interested, many different things, check out pediatricmoonshot.com, subscribe to the newsletter, LinkedIn, you can find me as well as Pediatric Moonshot. And if you're interested in signing this document of support for building a distributed AI lab, just reach out, tim@bevelcloud.io. So with that, I appreciate your time. I hope you'll join us in our Moonshot mission to reduce healthcare inequity, lower cost, improve outcomes for children who are not socially or postcode lucky by creating privacy-preserving real-time AI applications. So with that, thank you very much.
Wow, what an outstanding talk. So now we're opening our last part of this webinar. I'd like to give you the chance to raise your questions to the audience. I see that Tamar, that you already raised your hand. So Tamar, please.
Thank you. I'd like to thank EPTRI for organizing, especially REA, but everybody that's been involved in this really wonderful webinar series. I found all of today's talks fascinating, and I really congratulate the speakers on bringing this information in such a short period of time to all of our benefit. My specific question is actually way back an hour ago to Andrew. But it might be also relevant to the others, although I don't know that I heard it specifically mentioned. Andrew, as I recall, you mentioned that you didn't actually end up saving time in terms of the work by staff when they were managing the electronic records in the new system through the AI support, but you did very much enhance the patient's experience of doing it. If I'm remembering correctly, there was.
So actually, you reduce overall, so you do save quite a lot of time, but I take it with a bit of caution because it's in that very constrained world of a managed use case, as it were, with actors and clinicians. So in that setting, you save a quarter of the time of an overall outpatient clinic.
Oh.
So theoretically, you could get. Now, the way we've pitched it is you could potentially get you can use with that time what you want. Given that the waiting lists in the United Kingdom are quite long, you might want to see an extra patient, or 10% more patients. Now we have to see if those numbers work in the real world, and as we do our clinical setting. The bit that you didn't lose, so if you think of an overall consultation as having time where I'm face to face with the patient and time where I'm typing on a computer, you lost none of the face to face stuff. You just weren't breaking that conversation by typing.
Okay, but it's okay. So, okay, I understand. So it's a little bit different than I had understood before. But I guess the point that I was trying to also wanted to bring out was that in our own experience in using telerehabilitation, very often management is interested in using such technologies to actually save time and not just to enhance the user experience. And we don't usually save the time, but we sometimes have a hard time defending that. So I guess maybe my more general question would be to all of the speakers is that is there a need to convince the administration of using AI-based tools, even if you don't end up saving a lot of time, but you do end up perhaps enhancing the user experience, as I understand it was in Andrew's case, because the person actually felt that a person was talking to them and not just talking to their computer, or other benefits that you might have. So is there sometimes difficulty in convincing management to adopt these tools?
But can I just from a clinical perspective, I think the way that we always interact with our clinical teams and our patients is our priority is patient benefit. Our Second thing is clinician benefits. They often, how can we make the work that we do less mundane so that we can focus on the things that we as people bring? My gut feeling is in many of these, and then we've sort of touched on it, is actually commercial benefit, money, whatever, falls out when you do the right thing, interestingly. Not always, but often. So I think that's certainly the way. And clearly there's a huge amount of anxiety, for right or for wrong, that actually many of these algorithms are going to replace people. I actually would view it almost the other way around, as we know that clearly in most of the healthcare systems any healthcare system, having experts and having people who will deliver care that workforce is becoming more and more difficult. So if we can take away some of those, as I say, mundane tasks that we all do, so that we can focus on the things that we probably went into medicine or nursing or allied healthcare professions for, that would be brilliant.
Thank you.
More questions? I see, Paul, that you have a question.
Yeah, thanks very much, Harry. And I hope you can hear me, because my Wi-Fi has not been very good today. So firstly, like Tamara, I'd just like to thank all the speakers. I really enjoyed all those presentations, and I think they were all complementary in bringing a really strong message and lesson around AI. I've got two questions. I'll start with one and then come back to the other. So the question really comes to Timothy's talk about distributed AI infrastructure, and it probably is relevant to Andrew and Katarina. So a lot of the projects around AI use cloud-based platforms for data sharing, and use cloud-based platforms for federating data. And clearly that at a relatively small scale works, but then the opportunity to scale up to bring more and more hospitals in. Do you see a shift from using essentially cloud-based technologies, even in small research projects that involve data federation, to move into a distributed AI infrastructure? Or can you see that what would happen is we start in a cloud-based platform and then translate across to a distributed AI infrastructure as the data requirements become greater?
I suppose that question is for me. Hope this isn't too resonant. I think what probably is going to happen is, as I mentioned, we're working on this AI application commons because what we see is that whether you're in Korea or at UCL or wherever, there are teams out there, clinicians and AI software engineers, who are building applications in lymphatic diseases or cardiology or whatever. They are most likely building those in some conventional centralized method, whether inside the hospital or using AWS or Azure or whatever, which is fine. I mean, you can say, well, okay, you guys got together, you did that. To the question you asked, I think at that point, we just look at it and go, well, but we all know that it was not trained on enough data to be accurate. So that's why this whole idea of translational AI, basically moving those applications, to the edge, into the building, so that we can both see their effectivity as well as improve their accuracy, seems to me to make the most sense of how this will happen.
Great. And thank you, Timothy, for joining us. I know it's about 4:30 in the morning in Hawaii, so thank you very much for joining us so early. Hopefully you're an early riser, but that's credit to you for joining us at such an early time. I guess so. Just across to Andrew and Katarina around that, FEMS, from what I saw from the presentation, is based in a cloud-based system. I mean, would you see this moving over to a distributed AI infrastructure if there was an opportunity to bring more hospitals in?
Thank you, Paul. Is it only me, or did Paul freeze? Is it my?
Can you hear me?
No.
Can you hear me now, Katarina?
We hear him, but he's frozen in the image.
Yeah. So very. Thank you. Very shortly, if I understood the question is that yes, it is a decentralized ecosystem, and yes, all of our databases data lakes are cloud based. So the idea is indeed that it can be what's the word now in any language? Actually, we can increase the number of hospitals joining the ecosystem and the network, and that it is very scalable. The idea is to make it such that it is possible to scale it, and also possible to join the ecosystem, especially after the EU project ends, because we really hope to build an ecosystem of European hospitals, or hospitals which can join, so that we can actually share data in a federated way. So that is indeed the most important thing for us, is to create something sustainable that we could actually then scale, especially after the project goes forward. Yes.
Great, thank you, Katarina. And my other question really is about the heterogeneity of data in AI platforms, and I think this has been mentioned already. I know Lewis presented this in his talk, which is not just the challenge of rare diseases, but the challenge of heterogeneity in terms of gender variation, age variation, and also ethnic variation as well. The add-on to that is data in equals answer out, and there is an inherent risk of bias with AI algorithms. How are we going to get over that, and how are we going to essentially test the validity of an AI algorithm of giving us the right answer, given that it's so data dependent? And this issue of the black box phenomenon that I know people are talking about opening the black box, but actually opening the black box can be quite difficult sometimes with the algorithmic complexity. So how are we going to test the reliability and validity of the output if the heterogeneity isn't as great as we would like it to be?
I think, if I may answer, at least partially, you say already the problem. It's a black box, but it's not the algorithm, the electronic health records. Actually, in the US, for the last 5-10 years, there have been a lot of push through to open clinical notes so that the families and the patients can have access to it. And that has reduced a lot medical errors. They have improved the quality of the data, because at the end, the stakeholder that has more into the game to improve the quality of data are the families, the patients. So right now it's a black box. They don't know how those factors, the social demographic information, the social determinant of health is encoded. So if we have the families being able to check, annotate, complement the data, you are actually solving part of the problem. Then you need to have also the AI elements, that you need to do the audit to figure out that it's working. But in my opinion, we are missing an opportunity by not involving the families on checking and actually contributing data.
Thanks, Liz.
Well, Paul, maybe just get people to think slightly in a different direction. I think there's been so much emphasis on, quote, the data for obvious reasons. But, we've been talking a lot about application commons, and I think not data commons. So I think once you start thinking within a particular application, I don't know, a brain bleed application, a focal cortical dysplasia diagnostic application, I think it will be easier, right, to get through the question, which frankly nobody really knows, which is, how do we measure accuracy? How is it good enough? The aggregation strategies in federated learning, I would say we're still in the infancy stage to figure out, well, at what point do we say version 2 is good enough and deploy to all the nodes in the network? These are all not well understood, and I don't think they can be understood in a vacuum. And hence, we've been talking about a distributed AI lab. It was a little bit, I think the speaker before me was talking about them taking 3 applications. We're looking at 8 in all the different areas: oncology, radiology, cardiology, et cetera. And I think that will help us figure out, right, this accuracy question. on your question of heterogeneity, at least the way we see the world is, let's try to make things as standard as possible when they enter into the system. So part of the architecture we build is we have Philips digital twins, which twin Epic 7s down to Lumifys. So what that implies is that I don't care whether the Lumify is in Rwanda or in Liverpool, it doesn't matter. It will present data the same way to the applications. So if we can build, standardization, we'll call it that way, from the ground up, we can hope that over time we won't end up with, tons of heterogeneity, which I think if you go the reverse direction and start looking at big databases of, medical records and whatnot from multiple institutions, you face this problem straight off. And, while I understand why people do that, I think we're going to reinvent healthcare. That's not the path. AI does not, in my opinion, run on a billing engine, which is what most of these EMRs really are.
Yep. Thanks, Timothy. Katharina, you've got your hand up.
Thank you very much. Very short comment on the very good comments before me is that on the heterogeneity and the quality of data, I think it's really important to also, when we go forward, to take into account both clinical but technical perspectives to it, because of course we need to understand what clinical quality is and how we've actually what's the word? My apologies today. I can't remember any words in any language clearly. But how do we really store things from a clinical perspective when we have the patient in front of us, and that the doctors know that what they're actually doing and why they're doing it, and there's a standard with that, right? And we know that there are ICD codes and there are many other things that we do in a standard way, but actually in real life it's not so standard, but it's supposedly standard. And then there's of course the technical perspective that needs to be taken into account. And I think the requirements of harmonized data and how can we actually harmonize data within big data lakes is a huge thing, because it is very resource intensive and it requires expertise from different perspectives, as said. However, it is of course doable, and it is done more and more in different countries and in different systems. And for example, in FEMS, we're working with OMOBI's data, and we're working with OMOBI's data, knowing it's not the only one, but it's also a big data harmonization model that can be used. And of course, the more we do it, the more we understand what are the challenges related to it. And maybe from another perspective is that from a data quality perspective, I think it's also very important that we always think about what we're actually using the data for. Today, we have mentioned, for example, rare diseases in very small volumes, but we might use the same data for data process mining and huge data sets in which variances within data sets might not be as bad as in then with smaller volumes. So we really need to think about the so what and the use case of why we use the data and what kind of questions and challenges we're actually trying to answer with the data that we use. Thank you.
That's really helpful. Thank you.
Thank you. I see that Andrew, you raise your hand.
Yeah, just as another comment to Paul's thing, I think both Moonshot and FEMS to a degree, the principles are the same. We don't think centralized data is the right way to go. This is just not, it's just not going to work. There's too much data. The other thing of these distributed networks, though, is wherever you develop an algorithm and whatever population that will have in its innate biases, you should be really, really able to then quickly test it in another population and iterate. So I think that bit of these decentralized, however we do them, just means that you've then got much broader data sets from much broader groups of people that should hopefully enable us to overcome some of those issues. Really neat example during COVID, X-ray algorithm that works in a Chinese pediatric hospital does not work when you bring that to Spain. That's just didn't work at all. Different patient group, different disease, presumably presentation, but by doing that, you're able to then test, iterate, move on, test in a new population. And it maybe you need different things for different populations. That might be the way we do it. But actually, these distributed ways of having the data should enable us to do that sort of testing really quickly.
Great, thank you.
Well, maybe last question. If someone has a last question, if no, we'll conclude. Okay, so I just want to end with thanking again to all the speakers for their outstanding talks. Thanks to EPTRI for enabling this platform of webinar series. Special thanks to Paul, being the driving engine behind it, to Sandra that helped to organize everything. And I just want to thank you all for attending, for participating in this 6th webinar. Please remember that our next webinar will be on neonatal technologies and will take place online on September 17, 2024. Stay tuned.
Thank you, everyone.
Thanks, everyone. Lovely to see you all.
Thank you, everyone.
Thank you. Congratulations.
Thank you. Wonderful webinar.
Thank you. Bye-bye. Congratulations.
Can we see the record of the webinar later? It's going to be in the web?
Yes, the recording will be available on EPTRI YouTube channel. So when we have everything ready and all the information on our website, we will share with the people registered for the webinar.
Thank you very much.
Thank you. Bye-bye.
Bye-bye. Congratulations to all the speakers.
Thank you. Thank you for attending.
Thank you. Bye-bye. Thanks.
Bye. Thank you.
Bye-bye.